Okay, so this is a basic cheat sheet on all the little labs that you need to know and just like big things that they like to test on. Okay, so all of your lab levels are here. Okay, these are pretty much the ones that you need to know. Okay, and remember, the higher the number, then that means that they live intravascular. If the number is very low, then that means they live. If they're low, the number's low. That means they live intracellularly because we're drawing outside. We're drawing in the vessel, right? All right. So like, and you know the keywords because you did the video. Like sodium is brain, potassium is hard. Okay, you know these. All right. And then your kidney labs. So we talked about these. Remember, B1 and creatinine, those are waste products that your kidney should get rid of. If your kidney is starting to go bad because you're going in shock, right? Those are going to start to be elevated. Okay. And you'll need B1 and creatinine levels for all of time. Okay, you will be tested on this multiple times in lots of different ways. Okay, and then there's your urine specific gravity, 1.005 to 1.035, and urine output we want over 30 mLs an hour. Okay, I did include your ABGs. I didn't know they weren't going to do that this time, but you will need to know them at some point. Okay. Yeah, they're going to come. All right. And then I put in here, anytime I put something in red, it is very, very important. If I put it in a red bubble, it's even more important. So daily weight is the best indicator of fluid volume status. So we're always going to look at that over urine output. We're still going to do I's and O's, but that's more important. Okay. And then what we're going to do here is we're going to talk about fluid volume deficit versus fluid volume excess very quickly. And I want you to walk me through it. Okay. So I'm going to read you a sign and symptom, and you're going to give me a rationale as to why you would see that in your patient. Don't panic. Everything's okay because you look like you're panicking. Okay. So in fluid volume deficit, don't worry about the symptoms yet. What's happening in the body? What does that mean? There's not enough fluid. So what do you think their blood pressure is going to look like? Exactly. And then your heart's going to compensate by increasing. And our worst case scenario is shock. Yeah. So the worst case scenario of hypotension is shock. They'll go into kidney failure. Oh, I didn't follow that through. After they go into shock and their kidneys fail, then every single other organ is going to start to fail. That is called MODS, multi-organ dysfunction syndrome. So you'll hear and hear all the time, and you'll start, yes, your organs are start dying, and then you basically are calling in the family and yada yada. So you'll start hearing on the videos people be like, shock MODS death, because everybody knows that that's how it ends up going. Like it doesn't matter what disease you have, you're going to end up in shock MODS death, right? Because that's how your body is trying to compensate, and that's how you end up dying. You've probably heard of this before, and people say like, oh yeah, my so-and-so is in the hospital and they say your organs are failing. That's what that means. They went into shock, they're in MODS, and then you're just kind of waiting for them to pass away. It does not. It does not. Okay. All right. So let's go through fluid volume deficit. We know worst case scenario is shock. I'm going to give you a sign and symptom. I think you'll be able to do it. I think you know more than you think you do. Okay. All right. Tell me why a patient in fluid volume deficit would have hypotension. And the rule that I remember is less fluid in your body, less pressure. More fluid, more pressure. So if they don't have any fluid, then there doesn't have to be very much pressure to move it, right? Okay. And then you told me already that they compensate by tachycardia. Very good. All right. In a patient with fluid volume deficit, I would see dry mouth. Oh, dry mouth. Do you have to have a tongue to survive? Yeah, your tongue. You don't have to, right? You don't have to even really eat for a very long time to survive. So your body's going to start pulling fluid away from things you don't have to have, right? We already talked about that. So it can pull away from your mouth. It can pull away from your eyes. You don't have to see to live, right? Okay. So that's why you're going to see this sunken eyes and the dry mouth. And this is a big pocket, remember? Okay. Why would you see poor skin turgor in a patient with fluid volume deficit? Because there's not enough fluid. So what does the skin do? It sticks together because you don't have any interstitial fluid at that point. Yes, it's going to tend. Very good. All right. Oliguria. What's oliguria? Decrease urine output. So if they say A or AN, that means without. Okay. So anuria means, I mean, at that point, you're probably dead. So there's not very many times on an exam you're going to pick anuria. Okay. Because if you're literally producing no urine output, then you're probably nearly dead. Yeah. But oliguria happens a lot. And we would call it oliguria if it's less than 30 an hour. Okay. And why would you have oliguria with fluid volume deficit? Yeah, it's going to hold on. It's going to be very stingy because it's like, I don't have very much water, so I'm definitely not going to pee it out. Yeah. All right. Urine specific gravity greater than 1.035. Why would we see that in fluid volume deficit? Mm-hmm. What is urine specific gravity? Remember we talked about the urine specific gravity of water is 1.
Okay.
And the
So
further you would,
above that is gonna be more
that's it.
concentrated.
It just tells me the concentration of my urine.
Yeah.
Okay, is there a bunch of junk in it or is it nice and watery? Okay, you want your pee to be like pretty much clear to, yes, that's a low specific gravity. That tells me there's a lot of water in it. But let's say your patient is severely diabetic and they've got tons of glucose in their urine. That can make it thicker and more viscous. That would be a higher urine specific gravity. If you have a massive UTI and you've got lots of bacteria in the urine, that can make it more thick and viscous. So anything that makes it more concentrated, your urine specific gravity is going to go up. And in fluid volume deficit, it's only going to be high because you don't have any water that's coming out. Remember, your body got real stingy, right?
So it's gonna be pretty concentrated.
Very thick.
One.
No, anything above 1.035 is considered 0.035. Yes, is considered a high urine specific gravity. Okay. All right. Why would you have an increased hematocrit in fluid volume deficit?
Increased hematocrit.
That's it. Just increase hematocrit. When you have a fluid volume deficit, when you're dehydrated, why would your hematocrit increase? So start out with what is
the
it?
blood cells are just they're so concentrated.
Well, why would your blood look concentrated?
Because there's no fluid.
That's it. So you are a mixture of red blood cells, solid, and plasma liquid.
Yeah.
And if you have less of the liquid, it's going to make the percentage of the solid look higher. Very good. All right, now let's talk about fluid volume excess. All right, we talked about fluid volume deficit and you're worried about shock, right? Okay. Fluid volume excess, your blood pressure is going to be super high. What's the worst case scenario of high blood pressure? Okay, you could have a you could have an MI, but the worst case scenario is stroke. The pressure gets so high in the blood vessels of your brain, which are very tiny, okay, that it ruptures and you get a stroke. So hypotension, we worry about shock. Hypertension, we worry about stroke. Got it. Okay. So in fluid volume excess, you're still going to have tachycardia because you have a lot of fluid volume. Yeah, and you have a lot of fluid volume, right? So in tachycardia, it's going to be like, oh my God, I have to pump faster to get all this fluid out. All right. Why would you have hypertension and fluid volume excess?
Because you're trying to get because there's so much fluid and you're trying to
Yes, more fluid, more pressure. Yes. Bounding pulses.
Yeah. Your veins are.
So boom, 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 because there's a lot of blood. Okay. What is JVD?
Jugular
Yes. Distension. Jugular venous distension. So you're going to put them in semi-Fowlers, have them turn their head, and you're going to see their jugular go boom, 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 because they have so much blood volume. Oh, yes, you can see it.
Really?
Yeah, it's impressive. Yeah. Crackles. Why might I see crackles or auscultate crackles? Why would they have fluid in their lungs?
There's too much water.
Okay, so let's talk about that. Remember how we talked about how you change the pressure in the vessels?
You could be taking in excess water through.
Because if you're in fluid volume excess, they won't let you drink water. Okay, so remember we did the blood vessels, right? Okay, if this is a blood vessel of the pulmonary system, the blood vessels of the pulmonary system, they do have some pulmonary cells, but they also end up in alveoli. What's the alveoli's job?
Oh, to get the oxygen.
They're gas exchange. So so inside the vessel, we've got hypertension because you're in fluid volume excess. What happens anytime you change pressure in a vessel? Your body says something's wrong and it leaks into the third space, right? It's been doing that all over our body. Yes, that's what edema was, right?
Yes.
The third space in the lungs is your alveoli. So you start leaking fluid into the alveoli. So when I auscultate my patient, I'm hearing air plus fluid. Does that make sense? That's where crackles come from.
That's the third. See, we just learned that, just fluid in the lungs, okay, is crackles.
Yes. But you need to know how it got there, right? So in fluid volume excess, that's how it got there. Now, if a patient has pneumonia, that's from a bacteria, or so that's something different. But in this case, in fluid volume excess, their blood pressure is very high. Their body panics and says something's wrong, and it leaks into the third space. And in the lungs, the third space is alveoli. Make sense?
Yeah. They didn't teach us that.
Now you know. All right, and then in the rest of the body, you're going to see edema, of course, because you've got so much fluid. You change fluid or change blood pressure in the vessel. Your body says.
That's all third space.
It's all third space fluid. So most of the time, if they have fluid volume excess, I mean, they'll probably start out with dependent edema, which means legs, but then eventually they're going to get edema everywhere. Their face will be puffy, eyes underneath, puffy. Okay. All right.
When it's
Mm-hmm.
okay. So I'm just trying to think when
What?
it's that high, then do they add sodium?
When with fluid volume excess? No, they'll do a fluid restriction. So they'll say you
Yeah.
can't have any more fluid. And
But-
then they,
I was just thinking when the sodium draw the water out.
the sodium will draw the water into the vessels, right?
Okay.
But if you give them a lot of salt, it's going to stay in the vessels and then you're going to stroke them out.
Okay.
So you're going to give them diuretics because diuretics will pull the
Yeah.
fluid into the vessel and out the kidneys. Because you're right. I mean, you have the right concept that you're right. Salt will draw fluid into the vessels, but that's all it can do. Then all
Yeah.
you've done is give them a blood pressure of like 220 over 110.
that's
Yeah.
even worse.
Yeah.
That was just
But
like-
we do use that sometimes. Like if the brain is swollen, we will use hypertonic saline. We'll use 3% normal saline to draw that fluid back into the vessel, and then we'll get rid of the fluid. So your concept is correct. Okay. But in this case, we just need to get rid of the fluid. So we're going to
Yeah.
give them diuretics to do that.
Yeah.
Okay.
And not having to
Mhm.
drink anything.
Yeah. And then they get very mad about that. All right. Things I just mentioned a couple things about older adults because I usually like to ask questions about why older adults are more at risk of dehydration. And this is very self-explanatory, but I'll just read them to you really quick. They don't feel as thirsty, right? There's lots of medical conditions that can cause them to either not want to drink as much or medical conditions that can cause them to be more dehydrated.
Like a thirst center or something.
Yeah, the thirst center isn't activated as much. So they, unless they're actually thinking about it, like, oh, I haven't drank any water today, then they probably won't. Okay. And then a lot of older adults are on diuretics, which we know dehydrates you because it makes you pee, right? They do have a loss of nephrons, so they don't have as many nephrons available. And so nephrons are, the basic unit of the kidney. And so they may have more, a lower urine specific gravity, so they may get rid of more water. Okay, because their kidneys are not able to concentrate urine as well. It would be like probably closer to like 1.005. It's still going to be within normal range, but it's just more dilute because their kidneys lose the ability. Infants don't have the ability to concentrate urine. That's why like when a baby is born, they have 10 to 12 wet diapers a day. They can't concentrate their urine, right? And then older adults end up that same way. Okay. They have decreased renal blood flow, so they don't have as much blood flow to the kidneys. Well, if you don't have blood flow to the kidneys, you're not going to pee, right? You're also more at risk of shock, yes. Decreased cardiac output, so their heart doesn't work as well over time, so they might not have as much output. Now, as your heart beats, it comes out the aorta, and then it circles right down here to your abdominal aorta, and it goes directly to your renal arteries. Okay, so whatever's coming out of your heart, that goes pretty much directly to your kidneys.
So is that where it goes first?
Uh-huh. Yeah. Well, half of it's going to go up this way and half of it goes down this way, right to your kidneys and then down to the rest of your body, right? So if whatever's coming out of your heart is what's going to your kidneys, right? So if you have a bad heart, your kidneys aren't doing so well. Does that make sense? Okay. And then they have what we call a volume intolerance. So they're not able to tolerate large volumes at one time, right? So they couldn't sit here and drink this whole entire thing at one time, right? They would have to get smaller amounts, which can make it more difficult if you're trying to hydrate a patient because you have to do it slowly. Okay.
Yeah, everything has to be done slowly.
And it's hard for their body because we have to adjust our electrolytes and all of that when you're giving boluses of fluid. Like your body has to take the time to adjust, and theirs just doesn't adjust fast
Well,
enough.
when it's a bolus, it's fast, right? I mean, is it like over 2 minutes or something?
No, you can give it over like 30 minutes to an hour, but you're giving a large amount, like 500 to 1,000 mils. Yeah, and older adults wouldn't be able to tolerate that big of a bolus because their heart isn't going to pump it out well enough. Their kidneys are not going to filter it well enough. So I would give them a much smaller bolus. Okay. All right. If you have a patient on fluid restriction, they're going to ask you, like, what can you do? Because they're going to be mad at you, right? Okay. So stretch out the fluids and offer them like just a little bit every couple of hours instead of having them do a whole bunch at one time and then say, like, well, you can't drink anymore for 12 hours. That's going to make them mad. Okay. So we space it out. Use small cups. Yes, ice chips are helpful, but you still have to record that on the eyes and nose. It's still considered liquid. Yes. And then use small cups. Like I bring like shot glasses or something so that it looks full. Okay. Ice chips, you already said, don't give them dry, salty, or sweet foods because that's going to make them feel more thirsty. Yes. Oral hygiene is going to be really important because their mouth is going to be super duper dry. Right. And then they say no hard candy or gum because that makes it worse. I'm shocked by that. I read that too.
Yeah.
Yeah.
I've seen
I have seen both as well. So I would ask your professor and say, hey, if this does get tested on, what is y'all stance?
Yeah.
Because this is straight from the book that it says no hard candy or gum. But I have heard people that have like dry mouth, it's helpful for them to have something to kind of like increase their salivation.
It kind of just gets the juices flowing.
Yes, yes. So I think it'd be good, but your book specifically said no, so that's what I put on here.
Yeah,
Mhm.
yeah. Because I was kind of wondering about that. Because then I had read something that said the opposite. I was like,
Yeah.
oh, what? Okay.
Yep. All right. Did you do the video on the isotonic, hypotonic, hypertonic? You would remember if you did it. Okay,
No,
so
I did the two.
probably the one that said fluid electrolytes, maybe sodium, potassium, or something.
I definitely did like where you were, because I wrote notes on. I
Wrote note. Okay.
where it was like like the sodium and the potassium comes from the
Oh, the seesaw ones and stuff. Okay,
the
okay.
seesaw
So I'll give
stuff.
you a super quick crash course in this, and then there's a video on the playlist for isotonic, hypotonic. But all I'm gonna tell you is, okay, for this case only, when you're looking at fluids, take the word tonic and you're gonna replace it with salty or sugary. Okay, so it's how salty or how sweet you are. Okay, so remember when I told you like when you bite your lip, it tastes salty. We are made up of salt water, right? So how salty are we? We are 0.9% salty. Okay, because that's when you give normal saline, you give normal saline 0.9%. That's normal saline. It's the exact same saltiness as our body. Okay, how sugary are we? We are 5% sugary. Okay. And that's because when we give normal sugar to our patient, it's 5% dextrose, which is our sugar. So this is what we should be normally. So if you get an IV fluid that has these in them, these are isotonic. These are normal how our body is. So normal saline is isotonic. Okay. 5% dextrose, isotonic. Okay.
Yeah,
If
I
something,
know about the dextrose.
yeah, if something is less than these, then it would be hypotonic because hypo means low. So if it said 0.45 normal saline, that's hypotonic. If it said D5W, W means water. So I douse D5 in water, that would make it less than 5.
Oh,
So that's why it becomes a hypotonic solution.
Okay, so it's D5. Okay.
Yeah. If it said D, you're giving D2.5, that's a hypotonic solution because it's less than 5. Make sense? Then hypertonic solutions are anything that is higher than that, right? So normal saline 3%, D10, D15, D50, that's all higher than 5. Those are hypertonic. It's that easy. Okay. And the video goes over that. Okay. So just take the word tonic and put in salty or sugary, and that's it. Okay. Okay. All right. I did include your electrolyte keywords. That's from the video, right? The brain, sodium, calcium is muscle. You see where it says electrolyte keywords kind of towards the middle?
Right
Yep.
here.
All right. And then I gave you the basic assessments you're going to do in fluid volume deficit and fluid volume excess. You already know those by now. Crackles, JVD, edema. Okay. I gave you a cheat sheet for the seesaws. These are all the seesaws, right?
Yeah.
Those came from the video. And then your nursing diagnoses here would be deficient fluid volume or excess fluid volume, depending on where you're at. Or, and your number 2 would be a risk for electrolyte imbalance. Okay. But fluid volume excess or deficit will always be first.
Yeah, and tomorrow we're the thing is this test on Wednesday, but tomorrow.
This Wednesday? Oh. Oh, so you have 12-hour clinicals tomorrow and then you have a test on Wednesday? Oh. So this is your last day. Okay, well, let's move it. Okay,